So I'm going to be focusing on diagnosing superficial endometriosis, and we're going to be talking about this broadly speaking, but I want to share with you a novel ultrasound probe that has been really instrumental in unlocking the diagnosis of superficial endometriosis for populations that have previously been under-evaluated. Here are my disclosures. And we have here an endometrioma, and we have here a bowel endometriosis. We know these. I feel like in some ways the case is closed. We can diagnose these with skill, with accuracy, but we need to be moving forward and talking about the most common subtype of endometriosis. This is data here from my team in Canada, a combination of data from McMaster University and Sugo, my ultrasound clinic. And what I want to point out to you is that isolated superficial endometriosis is almost 1/3 of the patients that come into the operating room. This is surgical data. And these are the patients that are currently being told your scan is normal, everything is okay. We also have patients with normal scans that go to the OR. Of course, they don't have endometriosis in the operating room, but those patients are the diagnostic dilemma that we're currently facing. For those of you that are more in the ultrasound space, I always want to show surgical views to show you the diversity of how superficial endometriosis looks. It is an incredibly variable disease with different color lesions, different size, different surface area. Some stick out from the peritoneum, whereas some are very flush with the peritoneum. And they have some different names that we are using, like flame red lesions, cystic lesions, vesicular lesions. But the point here is you can see how diverse this disease is, which for us has to translate to the diversity of how it might look sonographically. Just to go back in time for a second, we know that for many years, we heard this. We cannot see superficial endometriosis on ultrasound. We saw this in many papers and many presentations, and I still hear it actually a lot and see it in papers, even though we know it's not true. And historically, most people were trying to use soft markers or indirect signs to identify superficial endometriosis because the belief was we could never directly see it. So let's try to indirectly see it. And we have all these features here that have been tested in diagnostic test accuracy studies. But unfortunately, none of these have proven to be strong enough with respect to their diagnostic test accuracy for us to use them in a day-to-day clinical practice. None of them have been included in guidelines around the world. And we also now know that biomarkers are becoming much more trendy. Saliva biomarker is available now internationally. Blood biomarkers looking at proteomics and microRNAs are being tested. But if we look at the systematic reviews on the subject and we look at consolidating that data, none yet seem to have that diagnostic test accuracy that we need for it to be integrated into a routine clinical practice and supported by governing bodies in our individual countries. Since that perspective of the past, I think that there have been a few fundamental changes that have led us to be able to know we can see superficial endometriosis and how to see it. The first is we understand the uterosacral ligaments much better, and that helps us understand the posterior compartment much better, including the peritoneal surfaces medial to the uterosacral ligaments, that of the pouch of Douglas, and lateral, which is the pelvic sidewall. We also have studied sonopodography, the installation of fluid into the pouch of Douglas, which gives us that distension, that ability to see the surface of the peritoneum. And from there, we have really realized that the utility of free fluid, which is there in so many women, we can use that as a window to see the peritoneum as well. This is going to be, I think, the most important change, and this is something that we have seen locally, and I know that colleagues from around the world have been seeing this as well, approach to scanning. And this is much more philosophical and social, but this is where we need to be thinking most, because you'll see the patient population that faces superficial endometriosis most is our youngest patient population. And finally, I always want to remind people that we have seen an international terminology consensus published by the World Endometriosis Society, AGL, ESHRE, telling us that we should be characterizing superficial endometriosis as disease that only lines the surface of the peritoneum, Anything that has any depth of infiltration, even 2 millimeters, could be considered deep endometriosis. So this 5 millimeter threshold that we used to use as the definition for deep endometriosis by this group of experts has said, no, superficial is only lining the surface of the peritoneum. So with respect to the approach to scanning, with the support of Samsung and my team members here today, including Ria Shetty, we have been putting together an adolescent assessment white paper. And we show you here this graphic of transabdominal ultrasound versus transvaginal ultrasound. It's not difficult to see that the clarity you achieve with transvaginal ultrasound is significantly more, allowing you to understand what the pathology is to obtain a clear and accurate diagnosis. Transabdominal ultrasound, you all know this, is intrinsically limited. How it can help us with subtle small pathology is challenging. In many cases, you do not see the normal anatomy, you do not see the pathophysiology clearly with transabdominal ultrasound, but so many young girls, teenagers, even adult women who are virginal have been declined in society assessment through transvaginal ultrasound based on beliefs, based on societal rules. We believe that autonomy is key. Patient autonomy is vital. A woman should have a right to choose what diagnostic test she wants to go through, whether she's 14 or 36, whether she's virginal or not. And we do offer every single patient transvaginal ultrasound. We also offer transrectal ultrasound. We advise people on the strengths and limitations of the different tests. And if they don't want to pursue ultrasound, of course, we can still do transabdominal ultrasound, but we tell them this is not going to be particularly helpful for an endometriosis assessment. And in some cases, we may consider MRI, but MRI is also intrinsically limited for lesions that are so small, like 1 millimeter, 2 millimeter lesions. And that's where my approach has changed because we have found this MiniER7. I walked up to the Samsung booth in Seoul. I saw this teeny tiny probe, and I'm going to walk it up and down the aisle just to show you relative to the other normal TV probe how small it is. And I will tell you that this was invented for the prostate, for a man, not for women. Nobody in all of society has thought, why don't we develop a small probe that can make women's ultrasounds more comfortable? But when I saw this probe in Samsung, I snatched it and I said, I want this probe right now. And since then, we have been integrating TV scanning in adolescents. And I will tell you some of the responses from the adolescents that have undergone ultrasound with this mini probe. It is the size of a finger. And thus far, almost no patients have asked us to stop the assessment. Not everybody consents to the assessment, and that's fine. We believe in autonomy, patient's choice, consent is vital. But it opens up the opportunity to scan them with much more comfort and tolerability. The MiniER7 is a really, really fantastic probe that was invented for prostate, but now we can use it for our female patients and provide more comfort during their assessment. And this is from the upcoming white paper showing you that with this mini probe, we can see superficial endometriosis very clearly. There is no lesser quality. Quality is the exact same, even though the probe interface is smaller. It's a fantastic probe from a quality perspective. We're going to see much more depictions of superficial endometriosis in the coming slides. And just again to show you, if we go back and forth a little bit here, you see how different all these appearances is. We have some filmy adhesions with hypoechoic irregularities, hyperechoic foci with filmy adhesions, cystic lesion, hyperechoic foci with an interruption, a cluster of hyperechoic foci, and a peritoneal pocket. And again, when we advance, we see again that diversity in imaging. One of those other things that has changed is our understanding of the anatomy. So here we have a sonographic depiction of a uterosacral ligament, surgically and sonographically. I'm going to point out the USL highlighted there, the USL highlighted here. This is the peritoneum of the pouch of Douglas in the rainbow color. And this is the peritoneum of the pouch of Douglas in the same view. And we can see that there's fluid here, which is the gray, and that's what we're seeing. This is an oblique view. When we have the fluid there, the peritoneum becomes visible. And knowing the surface of the uterosacral ligament appearance helps you orient where you are. Are you lateral, obliquely looking at the uterosacral ligament, or are you central, more looking at the peritoneum of the pouch of Douglas? And when we don't have fluid, you can still see those landmarks. So this is the uterosacral ligament here. And as we move the probe centrally, we're going to see that the peritoneum of the pouch of Douglas becomes very clear. This area will thin. It's thinning there. So that's still the uterosacral ligament. And the thinnest part in the central aspect right there is that peritoneum. So you can even see it when there is no fluid, the difference between those structures. Understanding this anatomy is really key. When there's fluid there, we can delineate these spaces much more clearly. So in the top view, we don't have any of the colors, but we have all the anatomy showing and then the overlays. Here, you can see the peritoneum, again, of the pouch of Douglas, just on the other side of the vagina. This, based on our data, is the most common location for superficial endometriosis. The uterosacral ligaments are next, followed by the side wall. Endometriosis is a dependent disease. This is the lowest part of the pelvis. And this helps us identify the rectovaginal septum and then the rectum and the serosa of the rectum here. And we can see that those are outlined in color just there. And then in transverse, this is a lot of fluid here in the pelvis. We can see the entirety of the rectuterine pouch peritoneum, pouch Douglas peritoneum, the side wall, the pararectal space, the rectum, and the serosa overlying the rectum. And this is that same view, but sagittal view of it. And this you can achieve either with saline infusion sonopodography, although you're probably not going to be doing that in a 16-year-old, or you can look for peritoneal fluid. And one of the upcoming studies that we're going to be looking at is the quantity of peritoneal fluid in adolescents. Anecdotally, it seems to be much more present, much more excessive. And so we wonder whether we can use that fluid to our advantage to see that superficial endometriosis in them. So fluid is your friend. Always use it. And here's the study that tells me that what we see sonographically, we know is endometriosis surgically. We have done the diagnostic test accuracy study to test this theory that these irregularities, these features we're seeing are superficial endometriosis with the reference standard of surgery and histology. And we are seeing around the world, more and more teams are finding that correlation in their centers, showing that this is a valid approach. The application of fluid or the utility of fluid in the pouch Douglas can be very helpful. And you may have seen this morning, we had our abstract presentation. So we had that 65 patients that we tested SPG on. And you can see for superficial endometriosis, we have a very low sensitivity. But when we introduce the fluid into the pelvis, we have a very high sensitivity for finding superficial endometriosis. So fluid, again, is your friend. Here we have a slide with a number of QR codes and titles, and we're seeing the growing amount of literature on superficial endometriosis. The most exciting, absolutely, is the addendum on the IDEA consensus statement led by Stefano, and I was very proud to be part of that addendum. And we're seeing groups, again, from around the world publishing their literature on this type of endometriosis, the visualization of it using ultrasound. At the very end of this slide deck, I have two QR codes, one of which contains all of what I consider to be the most important articles in a gynae ultrasound, including these articles. So if you don't catch it now, don't worry, it'll be again at the end. So here we have the IDEA consensus statement, and we can see that some of the features that we have already looked at from the white paper, we see here in the consensus statement. Hypoechoic associated areas, just there, small interruptions without much depth of infiltration. Hyperechoic foci. We have an interruption here, a small peritoneal pocket, a vesicle or a cystic lesion coming off of the peritoneum. And then in some cases, we have clusters of hyperechoic foci as well. And here's another zoomed up image of another series of visual appearances of these superficial endometriosis. You can see here for the majority of them, we're in the pouch of Douglas peritoneum, right on the other side of the vagina, literally millimeters from the tip of the probe. So very easy for us to see because they're so close. So when we start to talk about the features, this is how I think of them: direct and indirect. So the direct ones are the hyperechoic foci that are coming off of the peritoneum. On occasion, those may jiggle with the dynamic application of pressure, and sometimes they do not. There are the hypoechoic irregularities and the cystic spaces. The indirect features, which we must be more careful of because they could represent other pathologies: filmy adhesions and peritoneal pockets. And there was a great presentation by Christina Ross this morning on pelvic inflammatory disease in patients with endometriosis. And there may be similarities in the appearance of PID on ultrasound and endometriosis, or maybe these patients could have even both. So we must think of this differential diagnosis when we are relying more so on the indirect features. But the clinical context always matters. Even with direct features, you want to talk to the patient, know about their surgical history. Have they been through endometriosis excision or other pelvic surgeries? And have they had any infection in the past that could represent irregularities of that peritoneum? So I'm going to take you through what my steps are. I leave superficial endometriosis for last. Probably deep endometriosis, ovarian endometriosis are more clinically relevant. They're more advanced stages of this disease. They're certainly easier to see sonographically. So let's try and find those first. Leave superficial endometriosis for last. Always use fluid. It's pretty routine for us to check for fluid. Maybe some places people are quantifying that fluid. We don't really routinely quantify it yet in routine clinical practice, but we may start doing that for our study. And when there is fluid, you need to be moving the probe in and out to allow that fluid to fill spaces. I find the most effective technique is to actually retract my hand, almost like I'm pulling the vagina tissue with me to allow that fluid to fill the lowest part of the pelvis. For endometriosis ultrasound, the posterior vaginal approach, the posterior approach is, in my opinion, the key. The probe should be behind the cervix. And this is especially true for superficial endometriosis. We want this probe to stay in that space and go side to side, try and stay sagittal. And when you're trying to look at the side walls, it does help a little bit to go into the transverse view. And finally, if there is no fluid, still try to look. We still find occasionally hyperechoic foci, hypoechoic irregularities, but it is much easier when there's fluid. And it is okay to say, we cannot see it. We don't know for sure that it's there or not there. There is still diagnostic uncertainty. So let's just look at some videos now. This was probably one of my very first experiences with a mini probe. On the day I was actually trialing the probe, a 12-year-old and her mother came into my clinic with already many years of dysmenorrhea, starting to experience non-menstrual pelvic pain. And she had been booked in by her family physician for a transabdominal ultrasound for dysmenorrhea, which really is not going to be particularly helpful unless she has a large Mullerian anomaly, a hematometra, or a huge ovarian mass, and that's unlikely. So we talked extensively about the process of diagnosing endometriosis, the pros and cons, and we had the mini probe on site. She consented, and we can see very clearly this hypoechoic irregularity in the white circle on the peritoneum of the pouch of Douglas. And we were able to give her that visual validation in real time. In this cine loop here, pay attention to the surface. This is just the pararectal space beside the rectum. The rectum is just sort of obliquely in view here. This is that pouch of Douglas peritoneum, and this surface here is the pararectal space peritoneum. And you can see all these sort of little filmy areas, and you can see that they are almost floating in the fluid like seaweed underwater. If you've gone scuba diving or snorkeling yet here in Cancun, highly recommend, by the way. It looks very much like the way that the grass or the seaweed moves underwater. In this cine loop here, again, it's in the pararectal space, starting to be a little bit more lateral towards the side wall. We have this large cluster of hyperechoic foci coming into view right there. And this as well is representing superficial endometriosis in an adolescent with the use of the mini probe. In this cine loop here, see with the release of pressure, with the moving of the probe outwardly, we're allowing that space to fill with fluid. I'm retracting the probe. We see the development of the fluid within that space, and we see these filmy adhesions, honestly, just immediately jumping out at us. Keep in mind, in almost none of these views, the uterus is in view, the cervix in view. They're out of view. We're aiming the probe very posterior, looking at the lowest part of the pelvis. And here we have another view of superficial endometriosis, a number of hyperechoic foci, cystic area right there. You see the ring, and some endometriosis just here as well. In this clip here, we have, again, at the end of the clip, a number of hyperechoic foci. They jump out at you. They're slightly brighter than the peritoneum. They're not so bright like a calcification, but they're brighter than the peritoneum. And then just a number of still images. Again, these are all adolescents, young adults, virginal women who have used the mini probe for assessment. And we see the shared similarities across these 4 different patients. The multiple hyperechoic foci that are present in these patients. So it's there, it's very common. And once you learn how to visualize it, it will jump out at you, actually. It doesn't take very much effort to find it. So I think that the MiniER7 is an incredibly powerful probe for us to be able to use in individuals who have otherwise been declined transvaginal ultrasound, or who may themselves decline based on the size of the currently available probes, such as even the 2D probe that's here from Samsung. And from the study that we're looking at in adolescents, we can tell that this is giving them a diagnosis. It's high resolution imaging with reduced discomfort, higher tolerability, and they are giving us feedback. We're doing focus groups with them, getting their feedback in a study. It gave me answers. I finally felt understood, and many of them found it to be less intimidating as well. We actually have casings of these probes in the clinic as well that we can show the patients, not even with the wiring or anything, just to show them the differences in the size. And some of you may have heard me say this before, and I think this is so true in endometriosis. Diagnosis is therapy. These patients really suffer so much with their symptoms. They suffer with uncertainty, anxiety, fear. Knowing the disease is there doesn't take away many of the symptoms, but it gives them certainty. It gives them an ability to have a plan, optimism, hope, and get on the right treatment path. And finally, the message that's really important for you to take away for your patients is a normal scan does not mean the patient is normal. We cannot rule out superficial endometriosis. This message is the most important takeaway message, because when the patient is told their scan is normal, everything is fine, you're okay, that diminishes them. It invalidates them. And we are starting to hear the term medical gaslighting as well, and medical misogyny. We need to be really cognizant of our words. We need to make sure that we say this is a reassuring scan, no pathology is seen. However, we cannot rule out superficial endometriosis at this time. That means it may still be there as a cause of your symptoms. We are still going to validate your pain, take you seriously, and help you get symptom control, however that may be in your center. Thank you so much for your time. I think there are some minutes for questions. I think many of you know I have a social media platform. If you'd like to follow along on Instagram or subscribe on YouTube, I put lots of my content out on there. These 2 QR codes here are the most valuable ones for lots of resources and all the articles that I think are the most important gynae articles for ultrasound in the whole world of gynae ultrasound. It's my collection.